Well, hello and welcome to our newest session on Center for Podiatric Education. For our discussion today, we thought we'd take a look at the subject of laser management of onychomycosis. Our journals are filled with advertisements for laser units to be utilized for many purposes, one of which has been the treatment of onychomycosis. Generally, we have testimonials from various doctors, and we have presentations made at our meetings. And in this session, I thought we'd look at the actual data available and discuss whether or not there is or is not a legitimate place for laser treatment for the problem of onychomycosis. We know that the market is certainly there. In the United States in general, up to 15% of people are said to have onychomycosis, but of those patients presenting to the office for actual treatment of toenail problems and actually requesting a diagnosis, it's been estimated that between 65 and 90% of people presenting for evaluation do in fact have onychomycosis. We know that as we see an aging population, we have increased incidence of onychomycosis. It's a disorder associated with aging, and we know that Trichophyton rubrum remains the most common organism that infects the nails that we see. There is just a tremendous market in onychomycosis, and if we look at data that's used for investment purposes, we see that it's estimated that about 35 million people at any given time suffer from onychomycosis. About 36% of those patients are undergoing debridement. About 47% remain untreated. Only about 6% actually undergo oral therapy, and 11% undergo topical therapy. And this probably represents a fair estimate of patients presenting to the offices of podiatric physicians and surgeons. Traditionally, the most commonly utilized topical had been cyclopirox. We've had other agents introduced in recent years that certainly are more expensive and have been heavily marketed. Looking at the global onychomycosis market, you could see that it's predicted to continue to increase substantially up to at least 2020. And here again, it's estimated that there will be increases in the use of both topical as well as oral therapies for the treatment of onychomycosis. So certainly there's a tremendous market. We've seen major corporations get involved in marketing agents for the treatment of onychomycosis, and we will probably continue to see this increasingly. We know that if we look at companies that are producing pharmaceutical agents that are utilized to treat onychomycosis, we see projections of increasingly increased use, and there's tremendous money being generated in the treatment of onychomycosis topically. So you shouldn't be surprised to have these companies invite you to a free steak or seafood dinner, provide you with a nice speaker and some drinks, because there's just tremendous money being generated through these pharmaceuticals. And this is not something that's unique to the United States. We see uses of lasers throughout the world on an increasingly common frequency for management of onychomycosis. And again, from an investment standpoint, investing in onychomycosis treatment is being recommended increasingly by various companies that specialize in recommending investment opportunities. So let's look specifically at the use of laser. And the issue that we want to address is whether lasers are helpful for improvement in nail appearance only, or do they in fact effect actual treatment of onychomycosis. All of the current devices that are utilized are 510K FDA approved, meaning that the safety of the devices has been approved. But here again, we want to try to discriminate two things. there is a cosmetic resolution, cosmetic effectiveness, which is temporary increase in the amount of clear nail in patients who have been treated with laser for onychomycosis. And then there is medical endpoint, the actual elimination of the fungus infection. And I wanted to share with you the actual FDA recommendations, which of course are not recommendations, are not legally binding, and for that reason, at times I believe claims may be made that are in excess of the actual FDA recommendations. We know that as a practical standpoint, we do want to confirm that the patient does have onychomycosis. However, we want to remember that lasers are not species specific. So we know that we do not have, at least as of now, lasers that are specifically used to treat T. rubrum or T. mentagrophytes or fusarium or candida or other saprophytic fungi, so that all we need to really know is whether the patient does or does not have onychomycosis. Statistically, just by clinical examination, we will be correct if we presume the patient does present A, with onychomycosis, and B, most likely a dermatophyte, typically T. rubrum. But if we're going to want to have the patient go through the expense and minor potential injury with use of the laser, then we want to go ahead and confirm that there is in fact a fungus. We do not require species. Therefore, KOH testing would be adequate, and also PAS with or without histology would be adequate. Probably PAS is a more appropriate test, and the reason is quite simple. In the foot, we oftentimes have a mechanical component, that is to say repetitive microtrauma, which is associated with the fungal infection, perhaps even predisposing the nail to the fungal infection. So we want to have evidence that there is in fact a fungal infection, and really, other than genetic molecular testing, PAS is going to be your most sensitive test for determining the presence of a fungus, and a negative PAS is a fairly good, reliable indicator that we likely don't have a fungus infection. And also with histologic testing, we can determine whether or not there's a mechanical element, possibly some other elements to the disease. But speciation is not required, so we probably don't need to spend the money on either a culture or molecular genetic testing if we're going to proceed with laser surgery. We do want to remember, however, that appearance of the nail does not reflect the presence of the infection, so that the clearing of a nail does not imply or suggest that you actually cleared the fungus. So if your intent is to resolve the fungus, then simply relying on the appearance of the nail as looking improved is not going to be sufficient. And again, it may be necessary to do a tenotomy or arthroplasty or perhaps a hallux limitus surgery, whatever is required in the case of the patient that has a fungus infection superimposed on repetitive trauma. So the usual workup for the diagnosis of onychomycosis is appropriate. We look clinically at the patient's nails. We may use a dermoscope to see whether or not we have an aurora borealis effect or some other indication of onychomycosis. But ultimately, if we're planning on laser treatment only, and we understand that this is going to improve the appearance but not necessarily affect a cure, then either a KOH or a PAS with histology would be the appropriate test to do. When looking at the literature, it's important to remember that foreign studies may not be applicable. There may be an increased or decreased incidence of certain diseases or certain fungal infections in other countries. The other thing we need to consider are the patients in whom we most want to treat onychomycosis. We know that onychomycosis is associated with increased risk of cellulitis, infection, even gangrene and amputation risk in patients who are immunocompromised, patients who are on chemotherapy, patients who are diabetic, and we certainly want to effect cures in patients who have chronic venous insufficiency or lymphedema and have repetitive episodes of cellulitis. So in those patients, we want to do more than make the nails look nicer. We want to effect a cure. And in those cases, it will be important to actually treat the fungus, and therefore in those patients, speciation is important, and we'd want to have either a culture or going to the gold standard at the present time, molecular and genetic testing, so that you have to say to yourself, is this a patient in whom laser is not appropriate because we are not going to actually treat the patient? Historically, if you look at studies published and the evaluation of these studies, the Food and Drug Administration has allowed less than total clearance of the nail as being acceptable as an endpoint, and they will look for some improvement in the amount of clear nail, generally at 3 months and 6 months following the last treatment. You want to remember that toenail growth is somewhere between 1 and 1.5 millimeters per month. And the other thing to note when you're being marketed by laser companies is that many of the studies that are available, if in fact a particular device does have studies available, allow other therapies to be performed at the same time. So many of these studies involve laser treatment plus debridement plus or topical therapy plus or oral therapy. So what does the FDA specifically state? Well, the FDA recommendation is a little bit different than you'd suspect from the advertising. The FDA position on laser treatment of toenails is that it is indicated for adjunctive use, and I want to emphasize the word adjunctive, for temporary, and again, we want to note the word temporary, increase in clear nail in patients with onychomycosis. And the FDA notes that lasers should be utilized in conjunction with other treatments, such as manual debridement and antifungal therapy administered in a standard manner. So by FDA recommendation, lasers are not used in and of themselves for the treatment of onychomycosis. In fact, they're not even used for the treatment of onychomycosis. They're simply used to improve the appearance of the nails. And the FDA is very clear in their positioning that the standalone effectiveness of lasers for the treatment of onychomycosis has not been demonstrated. So according to FDA recommendations, again, a little bit different from the advertising that we receive and the discussions we have with individuals selling laser units, it's indicated for temporary increase in clear nail in patients with onychomycosis, and once again, it is recommended as adjunctive therapy to be utilized with debridement and or topical or oral therapies. The other issue that the FDA raises is use of laser therapy in patients who have diabetes or vascular disease or immunosuppression or any other condition that warrants the actual treatment of the fungus infection itself. And it's noted that the use of a laser should be considered cautiously in these special population patients, such as patients with peripheral arterial disease and diabetes and so forth, because these are patients that actually require treatment of onychomycosis. And I should say that this applies probably, at least in my opinion, to debridement as well as laser therapy. And we know that debridement alone is not going to be curative for onychomycosis, that we want to use debridement as a means to allow better penetration of our topical therapies or more effective or efficacious application of our oral therapies. So when considering laser, consider it as a temporary cosmetic means for addressing onychomycosis. It does nothing to actually treat the disease. And if the patient does have an immunocompromised state or a peripheral vascular state that requires treatment, laser really is not an appropriate therapy in and of itself. And the other issue is whether or not some harm could come to those patients. There is no correlation between clearing of the nail and actual resolution of the fungus infection in terms of it being definitive. Obviously, as the nail clears, there's an implication that one is successfully removing the fungal infection, but the presence of a clear nail does not imply actual treatment. Remember that lasers can cause injury to soft tissues, and therefore it is not recommended by the Food and Drug Administration for patients with vascular disease, diabetes, immunosuppressed patients, and patients with other conditions such as lymphedema or recurrent cellulitis. Some other issues that arise when looking at lasers for the treatment of onychomycosis is the fact that nails with 100% involvement, which we certainly see not infrequently in podiatry, can be very resistant to treatment with lasers, and so combined therapies are going to be required. Conversely, patients with less than 25% of the nail plate involved probably don't require laser treatment and will respond to other topical therapies. We also want to be respectful for the wavelengths that are utilized in particular lasers, because certain populations may show increased absorption or conversely decreased absorption, and we may get effects such as inflammatory hyperpigmentation from the laser. So the FDA recommended labeling is that patients be advised that lasers have not been demonstrated to be effective in the treatment of fungal infections. It is approved only for temporary improvement in the appearance. We know that there are multiple clinical presentations for onychomycosis. Commonly we see distal subungual onychomycosis, less commonly dystrophic or superficial white onychomycosis. And again, we want to be careful in being certain that the patient we're looking at doesn't have some other comorbid condition, particularly repetitive trauma. We don't know that lasers are or are not particularly effective in improving the appearance of one type of onychomycosis over others. We do know that in the majority of cases we're going to be treating T. rubrum, and again, between 70 and 80% of the patients presenting with onychomycosis likely have trichophyton rubrum. Going back for a second to confirm the presence of a fungal infection, looking at the available alternatives, if you're using a laser, we don't need to know the fungus, we just need to know that there is a fungus, and the most sensitive test that you could do under these circumstances would be a PAS with pathology if you also want to rule out the presence of some concurrent disease, because we know that PAS is the most sensitive test short of genetic testing. So your workup is somewhat shortened for these patients in whom you're going to utilize a laser. Make sure that you're evaluating patients for other comorbid conditions such as hallux limitis with hyperextension of the interphalangeal joint and repeated trauma to the nail from the actual hallux limitis deformity. Looking at endpoints in various studies and recommended endpoints by the Food and Drug Administration, they look at least 6 months of increased nail plate clearance over a 6-month period of time, so that we look at the patient 6 months later, measure the amount of involved nail, and look for proximal clearing. They then look for an additional 6 months with evidence of outward growing of the disease 6 months following the initial treatment. If there is less than 6 millimeters of distal nail disease, then the FDA mark for effectiveness of the laser is complete clearance of the nail plate following 6 months following treatment. If there's less than 6 millimeters involvement, and we do want to follow up with multiple evaluations. There are different ways to treat, or rather to evaluate nails for response to any therapy, whether it's oral or topical, or in this case looking at laser, not for treatment but for clearing. So you want to have some mechanism established in your office or clinic setting for measuring and evaluating nail outgrowth and response with improvement of the nail plate, proximal clearing, increased luster, and so forth. As far as endpoints go, here again, it's one thing to talk about temporary clearing, but ultimately, particularly in high-risk patients, we want durable reversal of nail changes at 6 and 12 months following therapy. And we often talk about mycologic cure mycologic cure means that we have improvement in the appearance of the nail, and we have a negative culture and negative KOH, or we're looking at 2 consecutive negative cultures. So we speak about medical endpoints rather than cosmetic endpoints, and again we want to see evidence that the fungus has been eradicated and the appearance of the nail dramatically improved or totally improved as a medical endpoint. So we look at various advertisements that are provided online and in newspapers, and in cases like this we see a relatively minor degree of onychomycosis. We certainly have less than 25% of the nail plate. We have localized disease, and certainly in a patient like this, response to laser therapy is not at all unexpected. 2 things to keep in mind in cases like this, however. Number 1 is, would a less expensive topical therapy have been appropriate? And of course we don't know that, but possibly it would have. And number 2, we want to remember that although the nail appears to be improved and is in fact improved from an appearance standpoint, we don't know whether or not we've actually eradicated the fungus. Some cases present, as you know, with more advanced disease of the dystrophic or distolateral subungual type. In cases such as this, where we obviously have an older patient who's edematous and has extensive disease, one would not expect, or we would have no literature basis to suspect, that in fact onychomycosis treated with a laser would be effective. So we see a number of advertisements for treatment, and again, some of these patients shown in the advertisements demonstrate a relatively minor presentation. Case like this, where we have distal disease, less than 50% of the nail plate. We don't see much in the way of involvement of the adjacent nails, and we could see that in this patient the appearance of the nail again is improved. Now, whether or not alternative therapies would have been appropriate, we would never know, but certainly in cases with less than 50% nail plate involvement, particularly the distal nail plate, absent any tinea pedis and without extensive disease of the adjacent toes, that frequently topical therapies are appropriate for the treatment of such patients. But again, the patients that come to our offices with feet that look like this, some possible degree of peripheral arterial disease or autonomic neuropathy, and presenting with substantial disease like this, we probably would not expect that laser therapy or even topical therapies would likely be very, very effective. Conversely, superficial forms of onychomycosis with minimal presentation of disease such as this would likely respond nicely to laser and probably would respond nicely to other topical therapies. So we see a variety of advertisements demonstrating various degrees of involvement and suggesting that laser would be appropriate for all of these patients. So do lasers work? Well, we certainly have a variety of so-called white papers available to us, and these are generally papers that are corporate driven, they're industry driven. There is generally some consultant or lecturer who is responsible for the contents of these studies. Many of these papers have not been through a rigorous peer review process. We also have various papers that are available in publications that are readily available to podiatrists on a basis essentially free at all times. And what's concerning is that many of these papers appear in journals in which there is substantial money being paid to the journal for advertising. And I'm not suggesting there's willful bias, but it always is a concern to me when I see articles suggesting here's an update in the latest and best technology and advances in podiatry, and we see papers such as this published in these journals, and these same journals contain half-page and full-page color ads advertising the products that are being discussed within the articles themselves. So I'm not sure I count this as literature when the sales reps hand this to me and tell me, here's a study. So again, looking at articles such as this, so-called Profiles in Excellence, and we talk about the advantages of laser therapy as a profile in excellence, and we have the advertising of the units that are being discussed in the article within the magazine. And I'm not suggesting this is appropriate or inappropriate, but it does cause at least myself to pause and sort of take this with so-called cum grana salis, if you will. The corporations are always willing to hand us various articles that are generated from their own corporation, and of course we have various testimonials always available telling us of the wonderful benefits of the lasers themselves. So what do real studies tell us? We know that the FDA tells us that lasers are approved only as adjunctive therapy for the treatment of onychomycosis, that we have to include real approved antifungal therapy and debridement, or I should say, or debridement. And we know that it is approved for temporary improvement in appearance. But what about the studies themselves? What do they show us? Well, efficacy data is actually limited. Most of the papers that you are given by these companies and representatives of the companies do not require mycological cure, nor do they require clinical cure. Most of these studies have relatively small sizes. The overwhelming majority of them have no control group. They have conflicting results, and the mechanism by which lasers are effective for, quote, treatment, close quote, of onychomycosis remains unclear. If you look at the studies available through PubMed and clinicaltrials.gov and Medline and Embase and so forth, here's the reality with regard to lasers. Mycological cures average 11%. Clinical cures average 13%. Clinical improvement ranges, depending on the study, between about 36% and 67%. The average clearing of the nail 12 weeks following therapy is 2.6 millimeters, so that the studies themselves, as concluded in this particular review, show that lasers meet the endpoints for aesthetic improvement only. Lasers do not meet the endpoints for actual medical improvement of onychomycosis, and we have no evidence whatsoever that lasers are superior to alternative therapies. We have a variety of papers available to us for review. Some of them are in vitro studies, others are in vivo studies, and there are a number of these papers that are available. If we look at the endpoints, they are very variable. Some involve inhibition of fungal colony growth. Some include complete clearance of T. rubrum infected nail clippings. Some look at complete clearance with T. rubrum and Candida albicans. We know that lasers vary in the wavelengths, and we know that the absorption of the laser energy is variable from at least with melanin and with hemoglobin and with water, so that different lasers may be appropriate for different skin colors. And different wavelengths, again, have been shown to be variable in absorption by different tissues. Some lasers have been shown not to be effective against Trichophyton rubrum, which is, of course, the most common infecting organisms that we have. If we look at some of the studies that have been used to market various lasers, this particular paper had 70%, quote, improvement, not cure of fungus, but 70% improvement, whatever that was used as a definition in this study. There was no control group, and there were no cultures taken following the study. Another particular laser that has been widely marketed in podiatry, the initial studies were small sample size, No cultures were taken after treatment, and the effectiveness was measured by observation of, quote, clear, close quote, nail growth. Another laser that was shown to be effective, but no control group was included in the study. We have studies such as this, again another popular laser, claiming 100% clearance of the nails, but only 38% negative cultures after treatment. So we did have follow-up studies for that particular laser, and a 38% mycologic cure. One of the problems, again, that I've wrestled with is the fact that some of these publications appear in journals in which the journal editor is a paid or has been a paid consultant and or lecturer for these companies. And I guess everyone has to determine what they feel is appropriate or not appropriate. And I'm not suggesting here any type of bias, willful or otherwise, but I am suggesting that perhaps some acknowledgement should be made that the journal editor has some corporate relationship with the individuals who manufacture the machine being discussed. Looking at some other studies that are available, we have the use of non-thermal laser therapy in 3 randomized open-label studies. No confirmatory fungal studies. The studies involve strictly visual diagnosis. Again, other studies looking at, in this case, the Novion laser, and looking at rates of cure, and mycologic cure rate as only 30% at 160 days. And again, a journal editor who is a consultant for the company. We have testimonials that are released to the medical community and to the public and to the podiatry community, and oftentimes these are thought leaders who are respected, whose words are listened to, but we have to remember once again that these are individuals who are paid consultants by these companies, and I'm not at all suggesting that anyone is biased or would willfully mislead anyone, but I am suggesting that it needs to be made clear when these types of announcements are made to our profession and recommendations are being made to consider certain therapies, that the consulting relationships between these individuals and the companies manufacturing these devices should be made very, very clear. What about the future? Well, in the future there may be a role for photodynamic phototherapy. I think we do need to look harder at standardizing research protocols. There may be a role for a chromophore-related laser therapy, which may be an improvement. We need perhaps to get better definition of wavelengths to be utilized, and the exact protocols for laser treatment, and the roles of adjunctive therapy in the treatment of onychomycosis. So, in summary, lasers are approved by the FDA as adjunctive therapy only for the treatment of onychomycosis. We have no evidence that lasers as a standalone therapy are effective for the treatment of nails infected by fungi. We know that the recommendations are that at-risk populations, that is to say, patients in whom onychomycosis represents a potential source of significant morbidity, should be treated for their fungus, and lasers do not affect treatment of those fungi. We know that the available studies are generally sponsored by corporations. They generally have small sizes. They generally lack control groups. They generally lack demands for rigorous fungal studies associated as endpoints. So hopefully this update on the use of lasers for the treatment of onychomycosis will provide some information for the listeners. Thank you for attending this session of the Center for Podiatric Education.